So we've got two panels tonight. The first panel, there's 4 scientists in that panel. We will focus on what we've learned so far about the SARS coronavirus and the pandemic itself. And I'll pose some questions to start us off. I'll keep an eye on the chat into which you can put questions at any point throughout the evening. And where I think questions that you're putting in at that moment in time are sort of pertinent to what I've been asking, then we'll bring those up there and then. But we will have half an hour at the very end where we'll run through all the questions that you put in your chat. So this is your chance to ask the experts anything you want about SARS coronavirus and the pandemic. I don't promise we'll know the answers, but we'll certainly have some opinions. The second panel will really focus on what the questions I want to ask the second panel are, what do we need to know? What do we need to know if we are to face pandemics in the future? I think this one has come as a huge shock to all of us. I certainly, as somebody who has worked on influenza in the past, have thought about pandemics. I've talked about pandemics, but never experienced one like this. And it's certainly something to live through, isn't it? So what have we learned and how can we apply that learning? So if we're better prepared, how do we recover for this one? And what are the questions we should be asking and answering now? So I'm going to introduce you to the first panel. So very quickly, if you want to have a look at our panelists in more detail, I'm sure they'd love you to. You can look on the college website, look at the coronavirus event there, and there's full biographies and some lovely photographs. So Dr. Giles Yeo is a program leader at the MRC Metabolic Diseases Unit in Cambridge. He's also a broadcaster and author. If you watch Channel 5 directly after this event, you'll be able to see him in his film on Why Do I Put on Weight? During the pandemic, he's carried out work looking at obesity as a risk factor for COVID. And I should say he also received an MBE this year for his work for services to research communication and engagement, something that's very important in this pandemic. Dr. David Matthews is a virologist at Bristol, working mainly on respiratory viruses, including now, of course, SARS coronavirus 2. At the start of the pandemic, his lab was the only UK laboratory working with Middle Eastern respiratory syndrome coronavirus. And that ideally placed them, therefore, to work on SARS coronavirus and use their knowledge of working with these viruses to help other laboratories. They published the UK's first paper working with live SARS coronavirus in a laboratory setting in March last year on the transcriptome and proteome of the virus-infected cells. And subsequently, they've worked with teams at Oxford looking at the Oxford AstraZeneca vaccine virus. Dr. Nicola Rose heads the virology division in a public health institute. The scientists in her institute have broad expertise, which covers 4 major areas: emerging pre-pandemic viruses, influenza, polio, and importantly for this discussion tonight, vaccines for viral diseases. Professor Julian Hiscox is chair in infection and global health at the University of Liverpool. He's got lots of other titles, but they're too numerous to mention here. Look at the biographies. His research group specialises in high consequence infections and biological threats. He is a co-opted member of the New and Emerging Respiratory Virus Threats Advisory, Virus Threats Advisory Group, otherwise known as NERVTAG, for COVID-19. So I think I'm going to start really by taking the 4 panelists and asking them, with your different backgrounds and interests, using that as a caveat, what do you think, with your setting, with your backgrounds, has been the most important discovery so far in this pandemic? And I think that could be either from a sort of virologist viewpoint, so what have we learned that's going to alter virology forever, or from the point of view of this particular pandemic and our management of it. If I can just start with you, Giles, sorry, because you're at the top of my screen.
So, well, thank you, Jane, for having me, and well, thank you to all of you for actually attending this. So, look, I'm going to answer from the perspective of my expertise, which is obesity, and I think if we didn't know it before, you know, that obesity is a problem, and we certainly knew this, but it is seldom that obesity per se kills you. Okay, that's not what actually kills you. It's the comorbidities of obesity, type 2 diabetes, certain cancers, high blood pressure, etc., that kill you. And now we know being obese or living with obesity increases your chances substantially of suffering particularly poorly from COVID. And so I guess the question is why? And look, I think a lot of this is going to be not an opinion. There's a slight editorial here. So I don't think we know with a capital K, I was going to say capital N there, exactly. But what do we know about why people living with obesity have this really substantially increased risk? We know that it isn't because of size. So it's not because of gravity. Okay, now that's an important piece of information. We know this because a lot of the people living with obesity have been mechanically ventilated. There is no issue of gravity or fat pressing down on the lungs. Nothing of that sort. But actually, the metabolic problems of suffering from obesity. So I guess the question is, why is carrying too much fat bad for you? Carrying too much fat is bad for you because your fat cells, in effect, get full up. The fat then goes into places they're not supposed to go to, including your muscles, including the epithelial, sacs in your lungs, including your liver, and causes all kinds of problems. Okay, and so this is the issue, and it also actually plays in. So this is the reason why carrying too much fat is bad for you, but it also probably plays into reasons why other things we know about, being male, okay, and certain ethnic minorities also have an increased risk of suffering incredibly poorly from that. And it's all about safe fat carrying capacity. Okay, so where we actually put our fat. So men can store fat less safely than women, just in general. Okay, women put fat in different places than men. Men tend to store it around their viscera, the beer belly look, and that is metabolically very, very, very bad. That increases your chances of metabolic problems, and that is probably a large reason why men have a disproportionate effect of suffering poorly. That's the first thing. The second thing is certain ethnic minorities actually store fat less safely. Okay, so for example, South Asians. So famously, we've now heard that South Asians really suffer poorly, but that's because we also know that South Asians have a particular susceptibility to type 2 diabetes without gaining that much weight. Okay, why? Because they have they have a lower safe fat carrying capacity before they tilt into metabolic diseases. So if you mix all of that in, that is why we think, mechanistically, I think it's still complex, but at least from an epidemiological phenomenon, that is why we think, and now we're beginning to learn why men, okay, as compared to women, and why certain ethnic minorities are particularly susceptible to suffering poorly from COVID. I'm sorry, I talked too long. That's it.
No, that's fascinating. And do you think so? So given this for SARS coronavirus, clearly different because we've got a massive infection across the world all at once, haven't we? So, but subtly, is it likely therefore that fat or obesity is actually a single risk factor for other infectious disease morbidities?
I don't know.
Hard to pull apart.
It's hard to pull apart. I mean, living with obesity comes with a whole lot of increased risk, but it doesn't, for example, increase risk of suffering particularly poorly from a cold. I don't think, you know, and so I don't really know. I think something about the mechanism of morbidity from the from infection from COVID is doing particularly poorly with obesity and this infection.
Yeah, thank you.
Someone smarter will give a better answer than that, but I think that's the situation.
I doubt it, but thank you. David, what about you, and with your sort of respiratory virus background?
What have I learned in the last year? I think the things that have not shocked, but surprised me the most is quite how quickly pretty much all of science can be pivoted towards a particular subject, and how quickly all of that can happen, and the sheer rate at which science can churn out data and papers most of it useful, thankfully. But probably the number one thing that has impressed me is quite how quickly we've managed to get vaccines together and get them into people's arms. That has been breathtakingly fast in terms of the awe of it, really, how quickly we can get the vaccines made, get them tested, can make sure they're safe, and then get them into people and see them have an effect. That has been quite eye-popping. I think that's been the thing that's impressed me the most.
Yeah.
I think overall, just the sheer weight of scientific output on this one problem has been absolutely eye-popping. It's nearly impossible to keep up with the pace at which things are uncovered about this virus, and that's been absolutely amazing to watch.
Yeah.
Particularly because just before it, as people like myself and particularly, of course, Julian, who's been working on coronaviruses a lot longer than I have, a relative backwater before. And the sheer, just the torrent of information has been absolutely amazing. And just making contact with lots of scientists in all kinds of disciplines all over the world, working with them and getting their input, that's been the bit that's been absolutely fantastic. So I think it's the pace and volume of what we've learned has been the most impressive thing. But probably to pick one thing out, the rapid development of safe and effective vaccines, that's been the single.
Yeah, thank you. I think that, if I may, I mean, Nicola, with your sort of knowledge, because one of the questions I get asked in sort of radio programs and things is, well, because the vaccines have been produced so quickly, how is it that they are just as safe? And I mean, I think many of us here know the answer to that, but can you sort of, well, go over that for us? But also, I think you've got more of a perspective on the perhaps the more global side of things, rather than everybody's heads here are focused around 2 or 3 the vaccines that we know and have deployed already. But I think globally, it's not just the vaccines we know about, is it? This is, like David says, much bigger than that.
I think it's picking up on that. If I was asked the same question, I'd say the absolute speed at which we've seen vaccines come to market is incredible. And it's not just that, it's the scope of the different types of vaccine. So we're now seeing novel types. So many people will be quite familiar with some of them from the childhood vaccines that you may have had yourself or take your children to have. And they might be an inactivated vaccine, so you get the whole thing and it's killed essentially. But now we're seeing new types. We're seeing types that are RNA vaccines. And this is bringing sort of new terminology to the viral vaccine field. And it's absolutely fascinating. I think some of the other bits that are coming through is the different types of vaccines and perhaps how accessible they will be to all corners of the globe. So if you start to think about, a nicely Western developed country that probably has very good access to ultra low temperature storage that may be needed for some vaccines, if you need to put vaccines into very hard to access areas, you need something that's stable at higher temperatures than that. And so those kind of developments and those kind of conversations you need to have to see what fits best where, I think has been really fascinating as well. So there's huge amount of development. If you go onto websites like the WHO, where they have a vaccine landscape tracker, or you go to any of the ones that have clinical trial trackers, you just see the scope and scale of the different vaccine manufacturing. And it has brought to the fore as well some of the big players that people would have heard of, but also some newer companies that may have had products in development for perhaps cancer, but not for a viral pathogen. So it's applying different technologies. You don't just have to sort of be quite blinkered about what you're doing. This is really an umbrella type science where you can mix and match almost. The speed of it, I think, could be deceptive, because what's not happened is that safety has been compromised. It's a little bit like having an accordion. You can have it stretched out as far as you like, but if you pull that all in together, you're not missing any part of it, you're just compressing it. And that's really what's happened. Ordinarily, you have a clinical trial and you have all the sort of the preclinical, the clinical, and all these different steps, quite paced, because manufacturers are perhaps making different products as well, and they have time to do this. this shows what you can do if both manufacturers and regulators and the scientists are willing to be flexible and, dare I say, agile, so that you can compress that, bring those closer in. But to do that, you actually have to make sure that you have the support. Lots of companies may spend years getting the finances together, for example. If there are mechanisms where that's facilitated up front, you can actually narrow that particular part of the process. So everything still happens, all the different bits of trials, all the safety checks and so on. But what people are doing is cutting out the dead space in between.
So one of the questions I get asked is, why doesn't that happen normally? We can't bring out vaccines every year, hundreds of them.
Possibly for some of the reasons I've said. You know, here there is a public health emergency. It's global, and so therefore action has to be taken. It's probably the biggest one that people have had to manage with the technology that we have available. And this is possible because it's happening now. So maybe 20 years ago, this may not have happened so readily. But I think there is an appetite for doing this because of the severity of it. Yeah,
thank you. There's a question popped up, which I'm actually going to ask Julian, if you don't mind, and then I'll ask you what you think is the single most important discovery. But the question is around vaccines, but with the sort of spike protein variants, what sort of challenges is that going to throw up, or do you think it is going to be a challenge for vaccines and vaccine makers?
So I don't want to tread on your next panel, Jane, but I think what we will probably see happening is that we'll roll out these current vaccines, and then we'll be doing our crystal ball gazing exactly like people do with flu. And then we'll say, okay, actually people are less well protected against, say, the South African variant, and therefore that'll go into our vaccine for the following year. So you will gradually build up a general immunity to these viruses. And it was interesting to hear what Nicola was saying about these things. You know, the adenovirus vaccine platform has been around for years. It was kind of brought out after the 9/11 due to Project BioShield, and was trialed for MERS coronavirus way before this virus ever came along. And so therefore I think we're going to be looking at a regime of agile vaccination as new variants pop up. Now, I would say that, you know, a lot of news has been about the Kent variant, and it's interesting to try and, looking at the question, to untangle the spread of these variants and how they spread. So is it because they've got some new biological property, which is where, you know, scientists such as we come in to investigate that, or is it simply due to what we call in virology founder effect, where you have a group of people with similar behavior patterns who spread the virus? So a really good example of that is the men who have sex with men community in the early 1980s, with a particular behavior pattern associated with the spread of HIV. So you can imagine with variants as they come along, you've got a group of, say, younger people with massive social networks who all interact with each other. They interact with their friends who again have massive social networks, and that's how the variants are mainly spread, rather than them, say, growing faster or being more efficient in what they do. When I think of a coronavirus variant, I'm thinking with my very old chicken coronavirus hat on, where a variant to me is something that causes respiratory disease with one particular variant, and another variant is nephropathogenic, and another variant is causing oviduct disease, and one variant is 10% fatal, and the next variant is 90% fatal. These variants that we have are marginal variants, but I would see the vaccine changing until we all become some global herd immunity.
Thank you. And Julian, what do you think has been the, you know, to you, what was the most, I don't know, exciting, influential, important discovery of the past year?
So again, I'm going to follow everyone else, and it's not necessarily a scientific discovery. I mean, as David said, we're making discoveries all of the time about the virus. I don't think we're finding anything new and fundamental about coronavirus biology that we didn't already know or could predict. I think, to me, the most exciting thing has been the fact that all of us are working with people we've never physically met before in our lives. And it's that level of trust that is immediately there. So we did a big study in my lab with a group of pathologists in Edinburgh called IceCap, and it was looking at post-mortem tissue of why people died of severe COVID-19. I'd never met them before, yet they were quite happy to trust us to do the job. And that has been absolutely the thread that has been running through science in the response to this pandemic, is just the sheer amount of global cooperation that's gone on. So to me, it's a bit hippie to say, but it's been the people relationships that I have found the most exciting discovery of this. I mean, I've worked with David for years, Paul, who's next, Ian and I, you know, we all go back decades now, but it's new people we've gotten to work with. That's been good. And our friends here as well.
It is interesting, isn't it? I mean, if you think back to HIV and the dedication by the MRC of the funds and you know, and other philanthropic people of funds for specifically HIV research, that drove then the massive collaborations, the grants, and it pushed things forward and made discoveries, which of course we use to this day. I think Ian would probably comment about things like the Ebola sequencing in the 2015 and then more latterly in the recent outbreaks too, where people, it is possible in science to get together and collaborate. We'll talk, I hope, I'm going to try and pick up on the communication of that science a little bit too, because I think that's also been the very key, that's been a very key feature. I mean, I don't know whether each of you might comment on that, because this is meant to be about, you know, what has just happened in that past 12 months. And it was slightly the bane of my life, the whole preprint business. Every journal came out with a preprint and every news channel picked up on it. So you constantly got phoned up about, have you seen this in the press today? And like, well, it's not been peer reviewed yet. But I'd like to get your thinkings about that. There's pros and cons, aren't there, at seeing research before it's really fully fleshed out. But how do you feel that works? So for the members of the audience that perhaps don't really know what I'm on about here, ordinarily a scientific paper can take a very long time to produce. We do the work, and even if you did it quickly in COVID, if you then went through the normal publishing processes, it could be months and months before that paper gets out there. Whereas during COVID, what's been happening is people have been, before submitting a full version of a manuscript or a paper, their research to a journal, they're able to get a preprint out. So get out there, this is what we are working on. We think you need to know this now because it's important. And that's sometimes where you would hear bits of research in the press, and I won't name names. Some politicians would perhaps say, I have just heard this, did you not see this? And then shortly thereafter, this paper would be, well, not paper, this research might be, how do we put it, but pulled and perhaps not emerge fully published. It's so good things, bad things about the whole preprint side of things. Julian, I think you were slightly ahead of Giles there.
Oh, so I'm schizophrenic on them, right? I use them, they're useful. You know, when you know a policy decision might depend on the science behind it, then they're useful. So on NerveTag, we rely on preprints because you know, it's an advisory panel, you get asked a question, and you have to look for that information. Now, a lot of it is done by people in their labs. You know, all of us on this call have retooled for SARS coronavirus 2 research. So, you know, we answer those immediately. And sometimes it's a little bit too knee-jerky. So different systems give you different answers. So these things called pseudoviruses that you can work with very quickly. There's pseudoviruses for SARS-CoV-2. People use them to look at antibody responses, but they give you very, very different answers to infectious virus. And so infectious virus is your gold standard, but that could take a couple of weeks to get a result with, whereas your pseudovirus might give you an answer in a day. And so therefore, you know, your policy or your advice changes on as the literature comes out. And from my perspective, it's very then hard to look back on coronavirus literature, because every time you type something in now, you're inundated with a wall of literature, a lot of it garbage on SARS-CoV-2, because it's not been through that peer review. So again, I'm schizophrenic. I use it because you want to get that information out. But then again, you know, at the start of the outbreak, we saw these things coming out saying, oh yeah, SARS-CoV-2, it's from snakes. And it's like, no, it's not. We all know it's not. You're just doing that to keep a certain government happy. And therefore, you know, that then can divert resource and divert people's thinking. So I'm interested to hear what other people say about them, Jane. But yeah, I'm mixed.
Yeah, they're a bit Marmite, aren't they? Giles, what were you going to say?
No, I think it really does. The answer is it depends. I mean, clearly that's going to be the answer. And I think certain things are going to be very effective from the preprint, for example, the sequencing. So at least for that, if you're able to look at the information, the sequence is the sequence, and you can look at it and you can make judgments based on that without necessarily the peer review step of it. I think a large part of the problem is the way the media has reported the preprints, because if they don't have enough experts, they have science reporters, but are not people who peer review papers. That is where I think a lot of the issues have come from. Governments have picked up, you know, multiple governments. You don't say our government. Most governments have sit there waving a piece of paper saying this is now what scientists have said, when it's what we've just written down. It hasn't actually been peer reviewed. So I think it's how you actually use the information. But for example, the classic example of the fantastic nature of it is the fact that the sequence came out as quickly as it did, and so we could then actually react and move and actually do stuff with it. And then the bad part is all the garbage that comes and the noise. And so therefore trying to work your way through the noise, I think all of us here peer review papers so we can pick our way through, but the noise then slows us down as we're trying to actually try and get the whatever, sheep from the goat, whatever the analogy might be.
I totally agree. I think a bit like Julian, they're sort of the bane of my life. But then also, you know, when you're looking to see who is working on what or for new ideas, they're wonderful, aren't they? I mean, yeah, difficult. Does anybody else want to comment on that? Or are you happy to move on? So yet another of my panel questions. So, yeah, this is a difficult one. But I do get asked this all the time in sort of media situations, and this is, you know, all our pandemic, and I know at least one of the panel 2 people will have an opinion on this, but we'll park that, we can discuss it at the end. But all our pandemic preparedness, and I remember I worked originally, well, not originally, most recently as a virologist for Public Health England. And all our pandemic preparedness was around the likely agent being an influenza virus. And you know, was that a wrong approach to take? I get asked that question, and so it's a little bit political, but and it's also fairly straightforward. But I'd just like to, you know, get your thoughts on this, because people in the audience would perhaps like to hear our thoughts. Go for it, David.
That's easy to say now, isn't it?
Yeah.
We could be sat in the middle of a major flu pandemic.
Yeah.
Just as easily. I think probably what's fairer to say is maybe at the risk of irritating colleagues who work on influenza, maybe conceivably you might argue that our focus is perhaps too narrowed, not just on the question of flu versus coronaviruses, but just in general, you know, we should broaden our thinking. And I think, you know, to be fair, that, you know, when you talk to people who have looked at this, that, you know, there have been studies in what would happen if we had outbreaks of other types of viruses. So But yeah, I think to solely pick out the idea that we were over obsessed with flu is a little bit unfair, because we could be easily sat in the middle of a flu pandemic. But
I'd like to, yeah.
But I think, you know, hindsight is a wonderful thing. But I think it would certainly teach that we need to be very broad in our thinking going forward.
Yeah, Julian.
Yeah, it's something that Chris Whitty addressed recently, wasn't it? The idea of following this flu pandemic plan, but it's the plan that we had for pandemic viruses, and I think nobody has done anything, you know, willfully negligent. Everybody's done their best, right? And that's all we can ask for. I think probably where we could have done things better is learn from those countries that have dealt with SARS and MERS previously. So, for example, and again, I'm commenting in a personal capacity here, right? Not in a nerve tag capacity, is that, for example, if we'd have instituted quarantine at airports, we might not have had the problem of the South African variant when we got it. So unless we're prepared to erode some civil liberties, then it is very hard to deal with vaccines like this. So the countries that have done well, China, Saudi, Singapore, Australia, New Zealand, have been quite draconian in their quarantine procedures, as we would see it in our democracy. You know, likewise, it's interesting about the vaccine rollout. So people of my parents' age remember what polio was like. They remember kids in leg irons. They've all been vaccinated. 95% of them have been vaccinated, right? Because they remember what it was like. They know that vaccines are a good thing. We get down to my age group now, and that vaccine take up is less. And, you know, my wife works in a vaccine centre. She had some guy in there the other day who was 80. He said, oh, I remember playing in some bombed out site in the 1950s. We just had these nurses come along, pulled us in and vaccinated for polio. There was no consent there. They just went around and did it, right? And I think sometimes, and I might be accused of being a little dictatorial here myself, but sometimes you can't mess around with these viruses, right? We have something, we have a vaccine that works perfectly well to stop people in my age group, 50 plus, just like Giles was saying, I have some risk factors now for getting serious COVID. I don't want to end up in intensive care with tubes everywhere up my bum with all my friends who are intensivists taking selfies next to me, right? I don't want that to happen, which is why I've been vaccinated. And we have something that's, you know, £10, £40 to give someone. You get COVID and you get hospitalized, it's cost thousands of pounds to treat you. So might I be slightly risque and suggest that if you don't have your vaccine, you pay for your COVID healthcare if you get COVID, because we're giving, it's like Giles is saying, there's a degree of personal responsibility. We're offering you something that stops you giving something nasty to other people, and yet people are not taking up. Whereas you go to Singapore, they're all about Singapore, society, bigger picture, not just me. So sorry, I've probably rattled on.
It's interesting, isn't it? I don't, you know, one of the things I should have done was make sure we had somebody along who was perhaps more on the human behaviour side of things. We will touch on it, I think, with the second panel. But it is interesting. Well, we haven't done that badly, have we? I don't know, Nikki, do you know what the uptake is currently?
Not absolute figures, but bear in mind that we've stratified in the UK who gets the vaccines. So, you know, we've gone from the older and the more vulnerable individuals down to the more younger age groups, obviously Julian's age group. So we've gone down that way, and it has reflected, I think, that you get higher uptake in the older age groups. And I think possibly for some of those reasons. There's also the aspect of the more social media as well. So I think there's lots more engagement from perhaps younger age groups as well with that kind of communication. which may not have been available or as widely used in the past. And so it gives people so much more access to different information, different debates, and whether or not you agree with either side or the one in the middle, you know, they are out there, and that causes a lot more discussion, and that can be really good, but it can influence perhaps the uptake as well. So that vaccine hesitancy against what, as you say, you know, my grandparents and my parents may just say, no, this is fine. We've seen, we've lived through an awful lot of disease. We remember when measles used to just, you know, kill X number of people a year. This is what we're doing. So I think it's age stratified for many reasons.
Yeah, it's interesting, isn't it? So you sort of lead by example, yeah, as well. Yeah, so we may end up averaging out rather like some of our neighbours ultimately. And we haven't got very long, so I'm just going to quickly have a quick look at some of these. We've kind of done that one. Just on the, so just thinking about the last year and public communication, and this is, so Julian was sort of touching on some of the things perhaps that have been less well communicated, but has anything stood out as, I'd like to start with, you know, good communication. What think people, either people or strategies or, I don't know, there's been very little actually on the TV and so on, which I've been quite shocked by. That seemed to arrive quite late, but good public communication and perhaps less good public communication. When's it gone well and when do you think it's gone bad? Are the times when you sat and cringed at the science that's being said by politicians, or I shouldn't pick on the politicians, on anybody, by anybody? Yeah, go Giles.
So I mean, can I start with the bad? Always start with the bad, but with the bad news. And I think because of this really quite obvious link between obesity, metabolic and metabolic health, and that is, you know, it's quite obvious. You can see people who are overweight. I think there is an element, certainly within some of the media, of there being some blame that look, you know, if you are of a certain size, then you are to blame if you suffer poorly from COVID. So that has been terrible. I mean, there's been weight stigma for a long time, but now there's weight stigma, you know, and saying, look, you're killing yourself really quickly. And then there's the second bad communication, and this has not actually come from the media. The media have just reflected, but either from the diet gurus or, dare I say it, some actual medical professionals, in inverted commas, I'm gonna put there, including doctors, who are now beginning to make money from it. They're selling books, immune boosting diets, whatever the hell that means. It doesn't exist. You know, and stop yourself from getting COVID by eating better. I think if we eat better, we'll lose weight, we'll be healthier, but eating kale is not going to prevent you from suffering poorly from COVID. And I think that has been an example of definite example of poor and probably dangerous, I have to say, scientific communication with regards to diet, obesity, and COVID. Good. I think people are now aware, you know, of the serious problems that obesity brings, and maybe, so for example, the Prime Minister having his Damascene moment after he came out of hospital, trying to put together some obesity plans. We're not here to discuss those flawed plans, but at least there is a plan that they're talking about, and so I think that probably has some positives from it. But from my perspective, from the nutrition and obesity point of view, it has been not good.
It's interesting, isn't it? I don't know. I mean, locally, we've had very good communication, I would say, within where we are now. Some excellent messaging and basically public health information. It's been very, very good. I guess the prime bad example is when you have let's just say a world leader giving advice like, you know, gargle or swallow Clorox, wasn't it? You know, that's inject. That's right, inject. That's got to be, you know, there was some very and very dangerous things said when you're on that sort of stage in this sort of situation. I think I'm just going to end it unless does Nicola or David, did you have any comments on that? Yeah, go David. Sorry.
I'm just going to quickly say a couple of things. One of the things that has impressed me personally, for the most part, when you speak to journalists, they're really keen to get it right. They're really keen to get it right.
Yeah.
From all newspapers and every journalist I've spoken to has been on it to try and get it right as best they can. I'm sure there's been cases where it slipped up, but for the most part, my interaction with it has been very positive. In terms of poor communication, yeah, I would think if you're the president of a country and you tell people that a vaccine is quasi ineffective, that's probably
yeah.
an example of really bad communication on the basis of no feedback. So yeah, there's been good and bad, and it's been somewhat surprising where some of the bad communications come from. But yeah, journalists, for the most part, my interaction with this has been very positive. So.
Yeah, no, good. Nicola, did you want to add anything to that?
Not too much. A lot of it's been said, but I think probably Jonathan Van Tam is probably a household name. And Chris Whitty, you know, they have become, you know, quite good figures in all of the communication, and I think people look up to them and respect them. And so with that kind of presence and that power to really inform clearly, I think is a big responsibility. But I think they've done that particularly well.
Yeah, I think you're right. Good. Well, we'll all be joining back up again at the end, and we'll have plenty of questions from the chat, I suspect. But in the meantime, I'm going to introduce the second panel. So Ella, if you'll do your re-highlighting, everybody. Fabulous, thank you. I'm going to, I utterly forgot to use everybody's professional names. Oh, and I've appeared in my kitchen, great. Anyway, apologise. So I will continue using everybody's first names, I'm so sorry. But however, so we've got Professor Paul Digard, who's a virologist at the University of Edinburgh, where he's chair of virology and head of the Infection and Immunity Division. And his lab more normally works on influenza virus, including in the past swine flu in the 2009 pandemic. But since 2020, like many of the other virologists, and as you've heard from the first panel, the research group focus has partially shifted onto SARS coronavirus 2. We've got Professor Ian Goodfellow from Cambridge, who's a Wellcome Senior Fellow and Professor of Virology and Deputy Head of the Department of Pathology here. And through funding from the Wellcome Trust, Professor Goodfellow and his colleagues have established the Arctic Network, which I couldn't find what the acronym was, Ian, and have developed a field deployable real-time sequencing workforce for for viral epidemics, which included that recent Ebola outbreak in the DRC ongoing, and the ongoing SARS coronavirus 2 pandemic, which is obviously ongoing. Dr. Derren Ready is a consultant in public health and public health infections, working for the government. And his experience during the pandemic is in the public health side of things. And amongst other things, he's looked at using, using LFTs as an alternative to self-isolation for testing contacts of people that have tested positive. Professor Paula Cannon is our international member of our panel. And Paula is, if I can get my computer to work, the Professor of Molecular Microbiology and Immunology in the Keck School of Medicine at the University of Southern California. And she's a world-renowned HIV virologist, which is how her and I know one another. But she's also a frequent speaker at both scientific meetings and in the media. And it's her ability to be a really good public communicator and describe the COVID pandemic that's made her a very sought after interviewee and journalist. So without further ado, I'm going to start in a sort of the same way as I did with the first panel, by asking each of you what you think the single biggest question is that we still have to ask ourselves. What do we need to know? I guess it's a bit open question. So what do we need to know now? What would be the single most useful thing that we could find out right here, right now? But then further down the line and thinking about, you know, getting to the end of this current pandemic, what do we need to know to get out of here? Sorry, big question. I apologise. Paula, do you want to start?
Hi, Jane. Hello, everybody. I had a feeling you might pick on me. So, as a virologist, I'm going to give you a non-virology answer. I think, the things that we're going to continue to learn about this virus and what it does in the body and how it spreads, they're all really important. But what we probably need to figure out is a bit more of the psychology of how we get people to trust scientists who knew they didn't, parse what they hear from politicians, and how we tap into people's desire for agency. And what I mean by that is I've been very struck by my, sort of friends and strangers who've, I get many emails a day with people asking me about vaccines typically. And I'm just really impressed with how people want to get information themselves. They are not sort of just waiting or even prepared to be told what to do. And of course, it's a double-edged sword. Depending on where you get your information from. I spend a lot of time kind of going, that's not exactly true, but let me see. So I think figuring out how we, going forward, how we engage with the population, how people can be given information and feel comfortable about making a decision, but also recognizing the role of the expert. So I think we have to kind of redefine it as scientists and public health workers. We should probably all go on communication courses and figure out how to do that. That's my wish for the next 12 months, really, is that because that's how we're going to beat this pandemic. It's not going to be a new discovery about the virus. It's going to be an effective campaign where people want to get vaccinated and are, trusting in the vaccine and their doctors and scientists telling them to get vaccinated.
I think it's absolutely crucial. I mean, there's a number of us here who were part of the Ebola response in 2015. And one of the things that we learnt then, and perhaps forget again, is that actually what mattered to get people to come forward, in that case to sort of testing centres or treatment centres as they were, and get them to engage in that, was to actually, it was the social and psych people that were actually working with people on the ground and understanding what held them back, why didn't they. So I think there's a massive social and psychological side to all of this. Yeah, really, really good point. Derren, you're sort of next at the top on my screen.
Okay, thank you. Well, hello everyone, and thanks for inviting me, Jane. I suppose for me in public health, the thing I'd really like to know or have developed is an early trigger for identification. Because at the moment, we are using a variety of triggers to detect people with COVID. Obviously, we're detecting the individual, and there's some testing using wastewater systems and looking for people pooping the virus out so that we can detect the RNA in the sort of waste that comes out of the setting. But they're just all a bit slow, and we need to get the public health measures in as quickly as possible, and we need to be able to sort of react to that in a very timely way, so that we can, do our job of trying to stop an extra person being infected. So I am really keen to look at different and novel methods for detecting the virus in the environment, or indeed, the wastewater I really like, but if you're not continent and you don't go to the toilet, your waste doesn't go into the toilet, and that is can be an elderly population that are the ones that we're really interested in trying to detect. So I'd really love a bit of development in that area.
Do you mean on the sort of surveillance side of things?
Yeah. So
do you mean during the pandemic or before?
I'm thinking at the moment, because you asked me to look forward, and now. So definitely now triggers that I could look at. So I have a particular region of England that I work in, and I can look at a number of cases in each region or local authority, and I can look at this wastewater data, but everything is delayed, delayed by 4 days, 7 days because of just the processes. And then I know there's a certain amount of people that won't get tested because, you know, maybe they distrust the testing regimes, or maybe it's not available to them because of you know, of them not being in, you know, being in particular institutions or something. So actually those early triggers, you often feel that you're chasing something that's already started. So anything to trim that time, I would be really keen to look at and have developments in.
Really hard to think, yeah. Difficult one. I mean, there isn't that much surveillance work done routinely. I mean, we've, well, in the past, you know, thought about ways of doing it, but it's not straightforward. Ian, what about, so that kind of plays in towards some of your side of things.
Yeah, well, for me, you know, thinking about what the world is going to be like in 12 months' time, what's the information that would be really useful for us? I think, you know, one of the big unanswered questions still is in the area of duration of protective immunity. Because, you know, with all the best will in the world, this virus is going to be around for quite some time. And I think we need to know whether here in the UK, if this time next year somebody turns up with COVID on our borders and it comes in, are our vaccines going to be effective? Are we going to, you know, there's been a lot of assumptions made. You know, we assume 6 months, possibly 12, but actually we still don't really know if, you know, 1 year, 2 years post-vaccination, is somebody likely to end up in the hospital if they get exposed to a slightly different variant of COVID? One would hope not, but actually solid data on that, you know, demonstrating that, you know, we would hope that if you've been vaccinated or previously infected, you know, 1, 2 years down the line, your chances of ending up in hospital from this virus would be limited. Don't really know that yet.
No, and it's invaluable, isn't it? And there must be data coming from China because they've had the virus the longest, haven't they? So we must, well, I suppose not with vaccines, but people that were infected and recovered. There must be a follow-up.
I think, I mean, maybe some of the other panel one members can comment on this better, but, you know, there isn't as much information coming out of China with respect to this as we would hope. And of course, their lockdown and control measures have been arguably a bit more robust than ours. So I think there's a lot of questions, a lot of unknowns, and how we respond to clusters of infection that we might see in 6 months' time or a year's time, you know, really depends on how much we believe in, you know, protective immunity, and do we need to do full border closures? Do we end up having to shut down entire regions again? I very much doubt it. But, you know, if we had hard data on duration of protective immune responses, I think that would be much easier to make those decisions in the future.
Yeah, fair point. Paul, what do you think? What's your...
I don't fret over vaccine or virus variants and vaccine effectiveness duration. Maybe it's my bias as a flu virologist, but I think there's going to be enough cross protection and enough immune memory that the vaccines are going to take this away as a major problem that overloads the healthcare system in the next year or so. I could be wrong. Something unexpected could pop up. The immunity could be very different to how most other virus immunity works, but I think odds on that as a primary problem, it'll be gone in a year, maybe 2 years, or at least under control. I think what we're worrying about more and more in the sort of the next year, and this comes back to a question that's popped up in the side, is all the rare things that happen to the unlucky few that catch a virus, that normally they get lost in the noise because there's no obvious cause. But when you have a natural experiment like this, where hundreds of millions of people are infected in roughly the same time period, you have the power to pick up the these rarer events. And the questions particularly about ME and chronic fatigue syndrome and so on. I mean, there was a wave of a mystery illness after the 1918, a mystery neurological illness after the 1918 flu pandemic that was never satisfactorily explained. There has to be a chance we'll see something like that with this virus, of which long COVID might be the sort of the forerunner of, perhaps, or an aspect of. So I think we're going to have to spend time trying to investigate and deal with that sort of outcome for the unlucky minority.
Yeah. So, I mean, what's interesting about having asked that question of this panel, as opposed to a similar sort of question, but on the, you know, looking back on a year, is that you all gave different responses. And I think that does reflect, I mean, it partly reflects on the different backgrounds of you all as well, but I think it reflects on just how much there is still that we don't know and that we do need to know. And I think and actually that was such a broad response, wasn't it? It was around the immunity, the sort of psych and social side of it, the public health and surveillance, and then disease pathogenesis. I think it's, you know, it's really, really interesting. Yeah, so applying, yeah, so I asked into the previous panel, didn't I, that question about basing, you know, our response. I mean, it was an awkward question, because what else did we base it on? We just based it on what we expected and what we knew, and we have, you know, we have to practice around some sort of virus. I think it was David is absolutely right. Maybe looking forward, we actually have to say, but what if it's this sort of virus? What if it isn't a respiratory borne virus? What if it's a blood-borne virus or comes from some other novel source? But thinking ahead from what we have learned this time around, it may come back to some of the same sorts of answers, but what could we do better? What could we, I mean, I think probably with, you know, Ian, networks like your own, and the way, you know, Nicola's talking to vaccine people around the world all the time, clearly collaborative work does happen, but how do we make everything happen a little bit better? What could we do better? What have we learned from this pandemic that going forward to whatever gets thrown up next? And I think viral pandemics has not altered in the list of major risks. I think it's still about number 3 or number 4 in global risks, according to the, you know, to the powers that be. And what would each of you suggest we've learned and should be taking forward? Most, you know, the biggest thing. Any of you? Sorry.
I think, I'm not sure if my camera's working, at least the chair's ignoring me. I think we need to be better at, well, I'm going to run the risk of sounding like Julian here. I think we need to be better at dealing with quarantine.
Yeah.
If something truly nasty came along that was 10 times the pathogenicity of SARS-CoV-2, we would just have to make decisions and impose quarantines faster than we did this time. And a year ago, every step that the UK took, I looked at it and thought it's too little, too late. You could tell that from the epidemiological data that we had then. We need to do that better next time. And there will be a next time. Can't say when, but there will be. I don't think any of the panel would disagree with that.
Why do you think we were slow to, I mean, if you remember back to 2015 and Ebola, we were testing people's temperatures, and, you know, if you came back, you were instantly in a sort of quarantine period just from working there, not, you know, we weren't infected, but we'd been there. We didn't, that did not happen, not for a very long time. Why was that?
Others may remember better than me, but maybe it was a hangover of treating it like flu, because for flu that wouldn't work with the time difference, or no time difference between being infectious and actually getting an obvious illness. Yeah. Julian, you'll remember for SARS it worked, didn't it? Temperature screening, the first SARS virus.
Yeah, I think.
So I don't know why.
Sorry to intrude on your panel. But I think, yes, I think with SARS though, it's more overt symptoms. I think one of the biggest mistakes we made in this outbreak was forgetting that asymptomatic people can also transmit. And there's a big body of evidence that for other viruses, coronas as well, that asymptomatic spreaders. So yeah, we were slow on it.
Yeah.
And I think you're right. If this virus had been more lethal, we wouldn't be in the problem that we are now with people disobeying social restriction rules. If we had a lethality rate of MERS or SARS-CoV, that would be a completely different kettle of fish.
Mm-hmm.
It's you know, it's also to do with with this virus. The risk is more kind of to everybody else in the population rather than necessarily you yourself individually. And the people who are spreading it, I mean, in the US, it's the sort of 20 to 35-year-olds who are not going to have serious illness in the vast majority of cases. So what's been challenging is getting across that message that we don't want you to get COVID. Not because of, you know, the asymptomatic or mild disease you might get, but because of the people you will give it to and the consequences for them. And it's been kind of distressing, I guess, to realize that people aren't that altruistic. You know, if it was SARS-1 or MERS and people were going to be really ill and dying and felt that personally, we'd have had a lot more compliance with things like quarantining, not going out and wearing a damn mask. But because there's this disconnect between the personal risk and the more sort of global risk, I think that's why people have found it difficult to understand the need for quarantine. And in, you know, the land of the free where I live, it's been massively exacerbated by being sort of wrapped up in people's individual rights and my freedoms and all that stuff. So it's just become horribly political and a nightmare to message in the United States as a result.
It's the same argument as for MMR vaccination, isn't it? Just writ large.
Yeah. Yeah. Derren, what do you...
Yeah, I was just going to come back on that a little bit about people's opinions to others. I think some people do have limited choice. If you're on a low income and you don't get paid, if you don't go to work and you can't afford to travel, not using public transport, or you have to car share. I mean, I think the burden of disease in those populations is something that I've found probably more surprising, even though I've got a background in public health, that how those with the least actually have, you know, often the worst outcome. So that to me was quite surprising. I would say for your pandemic preparedness, so obviously I have done the flu training. Probably first just worth mentioning that you do cover other pathogens as well as in your training for smaller outbreaks. But, you know, that training actually provides training for a whole range of people, you know, from the most junior person who's learning to log what needs to be done and work out how many people you can test, you know, in a week, to those making the, you know, the real key decisions. So there's a lot that carries over. But I think looking back, particularly with my own viewpoint, I think the guidance area has been very difficult and challenging. I supported that for a short period of time. And there's just a continuous hunger and a continuous question for guidance. And it's really difficult if you produce guidance that's very specific for one workforce or social group. Actually, then every workforce and social group also needs something, and they're all slightly different. And I think having some stock guidance very early that, you know, is supportive for most respiratory based infections, you know, could have saved quite a lot of time and help at the beginning, you know, for care homes. We did training in March last year for care homes, but the guidance didn't really come out until a bit after that.
Yeah, I mean, to be frank, with guidance, I was frankly in awe, because it has to change, it has to move, and it's, you know, to get it right and check through it, and
Yeah, it's very, it's a whole industry, and it's a whole industry just keeping it up to date once you've got it.
Yeah, no, I know on a, on a small local level what it's like, just trying to keep the messaging correct and aligned all the time, and removing old stuff is constant. Ian, what are your thoughts?
With regards to, preparedness, I think one thing that we haven't done particularly well in the UK was ramping up testing fast enough. And I think we used the trick, in terms of effectively tapping into academic resources. I mean, eventually that happened. I mean, there are very good reasons why all of a sudden you can't switch a switch and turn every lab with a PCR machine into a diagnostic lab. I mean, you yourself know that, but I think there was a lot of resistance back in wave one, where there were quite reputable institutions offering, quite substantial capacity for testing to the local authorities, but that was being knocked back because accreditation wasn't in place and so on, and for various reasons. And I think to maintain diagnostic capacity at that level nationally, the costs associated with that are huge. So you almost need a reserve capacity that can be ramped up relatively quickly. And I feel that, it would be possible to somehow coordinate with key institutions around the UK, research institutions that have the relative equipment, and to bring in people like yourself who've got that expertise in diagnostics to coordinate and use that capacity more effectively. I mean, eventually that was happening, but it wasn't really until 6, 8, 9 months into the epidemic where people started to allow university laboratories and research institution laboratories to do testing, and that could have been done faster. And I think the impact of that, and thinking about how we can harness academic resources more effectively as a sort of reserve, I think
I'd say academic. Yeah, I totally agree, but I'd say industry as well, because once they got involved too, that was a game changer. And locally there's still some of the smaller biotechs getting involved, and they're doing a damn fine job of it as well. And that could have been done. I think there is something around that, and sort of the remaining preparedness side of things, that sort of keeping a log, and the way that they, in the past have kept logs of people who can work at certain levels, who are capable of, responding and being able to go and work in certain situations. I think you need to be able to do that with probably all biotech companies and all molecular labs around the country. Yeah, absolutely.
It wouldn't have, the legislation around it and the accreditation, but there are people around the country who could be brought in to sort of manage that, and say, okay, this is how we do this properly, without reliant on people like me to try and make it up from scratch. But that really didn't happen, and it was quite slow and actually quite frustrating for the people who were offering help and being knocked back constantly.
Yeah, which sort of sounds familiar, doesn't it? reminds me of not so long ago. But yes, it's interesting. I think so to actually, just to bring it, not local, but schools and universities have been a real discussion point. I'm kind of interested, Paula, to hear your international take on this, because we have gone up and down in this country here with, should schools go back? Should they go back now? Is this a risk? And the last time I looked at the data, which I have to confess is probably about 6 months ago now, because I lost the will to live. There's so much of it. And Derren might have a thought on this too. But where do we fall out? So I suppose it may be virus specific, but with respiratory viruses, if I can say that, what do we think about schools as mixing places for viruses? I know, and we all know, we're all familiar with the public discussions about, but we need to get the kids back so the parents, A, stay sane, and B, can get back to work. There's a massive side to it. but how much of a risk are schools? And I remember us discussing this in swine flu 11 years ago, no, 10 years ago.
So I think the data in the United States now is very clear that as long as you've got a decent testing system in place,
yeah,
the kids should be in school. And we do have decent testing systems in place now. Just to sort of piggyback on the prior conversation, it was a shame it took so long. I remember back in March, you know, getting together with a couple of other academics at my university, arranging for shipments of saliva collecting reagents, hooking up with a local biotech company who could do sort of high throughput screening sequencing as the way to test it, putting the package together, being super excited, going to the clinical pathologist and being told that I wasn't a CLIA certified path lab and they wouldn't make me one, so I couldn't do it. Super frustrating. I also then have friends who happen to be on a school board in Chicago who went to their schools and said, you know, as long as we get the tubes, we can set up testing on the playground. And so their school went back straight away because the scientists who happen to be parents just set up a kind of, you know, a pop-up testing system. And I've seen all sorts of things like that developing. And so really, I think as long as you're going to test the kids, and I would recommend twice a week, I think it's completely safe, especially now, I presume, I don't know what it's like in the UK, but in the States, you know, all our educators should be vaccinated by now. So, you know, it's going to be a problem for them. Yeah, sorry.
It's one of those questions, yeah, which I don't know if you're in the chat or not. How are we doing time-wise? Sorry, I've not been keeping attention. We're okay, good. So Paul, Derren, Ian, on the side of schools and universities, and I mean, I wasn't putting it out there as a political, it was really to sort of, I mean, if we, as long as you've got testing, I can see that it's perfectly fine. Is that, Derren, what's been the sort of experience on the ground?
So if I think about my sort of local experiences, so when the universities first came in sort of into full action in around the September, October, we did, particularly in some of the larger university cities, have an uplift in that age group. Very interesting. It didn't always, well, in fact, frequently didn't overflow into the local population. So it was sort of held within the university, even in one university where we had over 1,000 students in campus with COVID detected. The rates in the city and the wider population were unaltered over that period. So that was interesting. I remember myself as a student, I didn't really go out and hug all the local people. So I think that was interesting. And then that age group sort of dropped down. With the schools coming back, I think the sort of general principle that children tend to have a good outcome if they get infected. Teachers are often of working age and therefore like to have a good outcome if they get infected, you know, thinking of the worst thing that could happen. So actually then they're not the groups we're most worried about for outcome post-infection. And if we look at the actual sheer numbers of cases, you know, they are pretty low in the school setting, particularly in sort of the nursery and the secondary schools. When the secondary schools first came in, they were a bit high, but now they're actually really low. So there's a slightly stronger sort of trigger of number in primary age children, but it's still not as big as other settings. You know, that we might, you know, equally might be more interested in factory workplaces where lots of people come together of the working age, or indeed even prisons or other institutional settings. Yeah.
Ian, what do you see on the sequencing side of things? So does that, you know, I mean, Derren's obviously talking about sequencing with the schools in his region and not seeing spill out into the public. Is that seen across the country generally?
I think it's difficult to comment sort of across the country because not every university has had, you know, been fortunate to be able to basically test their students and sequence them within a time frame that's useful. I mean, we're very lucky here in Cambridge because we have the Lighthouse Laboratory and we have our sequencing laboratory, and we very rapidly set up this sort of workflow where the samples will come in for sequencing within a day of them landing in the diagnostic lab. And we had a similar experience in that, as far as we could tell anyway, most of the cases stayed within the university. We had some quite interesting clusters and say large outbreaks. There was something like 370 cases all linked to one, let's say, social event that happened, and could be quite easily tracked through the university, various colleges, but they all came back to this one event that had happened, and there wasn't as much mixing with the community as we might imagined. The one thing that did come out from that, which was kind of interesting, was medical students, and potentially the idea, that we were having medical students who, many of whom were based in college, who were getting infected with viruses that were circulating in the hospital, and then bringing it in to their college. And, there was discussions around trying to ensure that students that have any interactions with clinical areas are prioritized for vaccinations. And I'm not sure that, I think at Edinburgh, they probably were, because any on site had active vaccination. But yeah, we didn't see as much mixing. Similar to Derren, really, it was quite limited to within the university, which maybe just reflects the nature of Cambridge the way it is.
It's always hard to tell, isn't it, with the sort of Oxbridge setup and perhaps one or two other universities, that you imagine that the students are more insular, if you like. They interact more within the colleges, but that might not be the case. I don't know. I mean, Diggs, do you have any feeling for up north of the border, and what I don't know what opportunity there has been up there to sort of sequence within specific institutions and look more broadly. Paula, I don't know what you've seen at the university level. It would be interesting to know whether this is a sort of more enclosed university environment, or perhaps where they're, I don't know, a sort of, I don't want to point at any particular university, but universities up north, for instance, in the northwest, where there've been some large outbreaks. It'd be interesting there, because I know those students live throughout the city. It'd be interesting to see if they then get more mixing of strains and so on. I suppose that would be the wisdom, wouldn't it?
I'm not aware of anything like that in my area. There's been very little transmission within campuses that can be definitively proven anyway, as far as I can tell.
And then so campus being where they live, or where they sorry,
where they're taught.
Where they're taught, yeah. That's, I think. But I think that's sort of what we've seen more locally as well. You don't see it in departments, but you might see it within where they live. Yeah.
One of the challenges we have is our infamous so-called spring break in the United States, where our college students, even our college students who are doing online university, feel the need to go to Florida or Cabo or somewhere hot. And that's really what drives little mini outbreaks at campuses. It's always linked to travel, either travel home at Christmas or Thanksgiving, which is in November, or now travel at spring break. So we're, in Los Angeles, our numbers are pretty low at the moment, pretty good. It's amazing how we got them down, and we're all just kind of keeping our fingers crossed to make sure that nothing starts to flare up as a consequence of national and international travel to go get some sun and sand.
What's the current status in America for travel then?
Oh, you can travel. Let's see. Again, it's all the states have different rules. So, for example, and there are rules at the federal level, the state level, the county level, and the city level. So, where I live in Los Angeles, anybody traveling into California or Los Angeles is asked to quarantine for 10 days.
Oh, well.
Do people quarantine for 10 days when they travel into California? No, there is no mechanism to enforce that. It's kind of like a polite request. if you want to travel to another state, for example, if I wanted to go to Hawaii, which is, you know, sort of abroad, but still a US state, I have to get a negative COVID test 72 hours before I get on a plane, but that's the only restriction. So there's really no barriers to traveling within the United States, although some states do request that you quarantine. And I think it reflects the reality of the country. You know, public health decisions get made both on what makes sense, but also what you think you can actually enforce. And clearly, we can't enforce a ban on travel.
Got to be pragmatic, I suppose. So, okay, let's have a, I think we can all reconvene now, can't we? Yeah. So if the rest of the panelists want to join us, and we'll have a look through. I'll have a look through the questions actually, and I don't know if we know the answers to all of these, and I missed some of the early ones, so I will apologise to the people that asked the question. What I'll do is I'll ask the questions in the text here, and then when the panelists have answered it or had a go at answering it, then if the person wants to, if you remain silent, we'll take it that you were happy with the answer. If you think, actually, I would like to follow that up, feel free to unmute then. And I think you can, can't they, Ella? You can unmute and just broaden the question if you want. So the first question was, it was very specific. It was about the Oxford AstraZeneca vaccine. And why is it apparently and I think probably a number of us can answer this question, but I'll let someone else. The only vaccine apparently being picked up for causing blood clots. Does anybody want to answer that question? Is that Giles? Is that a hand or no? It sits on that hand. I've heard one of my colleagues, Chris Smith, answer this question and point out that the level of blood clots, or those particular types of blood clots in the population being studied in that particular clinical trial was actually lower than in the general population. I think that was the answer he gave and the only answer he would give to the question. So I think it's a vanishingly small effect that was seen, and Nikki may correct me on this, but when it was then, why it halted the vaccines rollout in Europe, I think was a sort of technical thing really, wasn't it? Am I right there, Nicola rather, sorry, that basically that was part of their review process, and it seemed to pause for proper legit reasons.
So regulatory bodies will often do this. It's not unheard of, it's not unusual. Bear in mind this is a relatively new vaccine for a new disease, and so you can't know everything about it immediately. And so it's not just this particular vaccine, it could happen for any of them, where if they felt there was something as a safety signal, as you might call it, then they can halt the rollout and wait until they have sufficient information that perhaps looks at the risk benefit of having that vaccine for a population. So it's not an unusual thing to have done, and that will be under review, for many of them. Bear in mind that there are, a limited number of vaccines that have been used at scale so far. And so when you're running clinical trials, for example, smaller numbers, you may not pick up the very rare events that could happen. But just because they happen also, it's not necessarily a causal event. So there's a lot of information that still needs to be understood. And it's why the regulators look at these in a lot of detail and put a lot of effort in to understanding the numbers, to understanding whether there's a cause to them. And so this will continue.
Thank you. I hope that Reg is happy with that answer, but that was pretty comprehensive. Thank you. And there's a question for Giles, which Giles has probably read. How much do we know about the pharmacokinetics of the drugs that were used initially for the treatment of COVID? Could it be that obese patients are dose, since none of the drugs were ever tested for COVID before. I presume that's perhaps the person's talking about a sort of weight dosage ratio thing. Could it be, because these drugs have not been used in a range of patients before, could it be a contributing factor? PK differs in obese patients lots of times.
So, I mean, I'm not going to know exactly for every single drug, but given that people living with obesity have so many comorbidities and do end up in hospital relatively frequently, I mean, I would have thought that someone would have thought about that bit beforehand. And I really do not think, actually, that ultimately the key driver of why people with obesity suffer from it is not because they're getting too low a dose of drugs. I think that would be the short answer.
Thank you, Giles. Succinctly put. So I think we answered this one, didn't we, Julian? This was the regards to the new variants. How does the change in spike proteins? Yeah, it's a question we get asked a lot about, and I think Paul also touched on the answer to the vaccines. So hang on. So yeah, so this is another one that we get asked, isn't it? So staying ahead of the disease, has a slightly political answer here, but so elsewhere in the world where perhaps the virus is less well controlled, I guess a way of asking that question would be, what sort of a threat does that pose? So how do all of you feel about the fact that in some parts of the world, I mean, we're talking about, and I think Paul gave a very, positive response, saying that we can get through this within a year. I think likewise, Paula with the state in the States, or in her state anyway. But actually there are pockets of virus out there that are less well controlled. And how do we feel about that as an ongoing risk, Julian?
I think it's a large risk, because I think what it means is that we're always reactive and not proactive. Now, whether the variants in those countries will actually be a risk for us is another thing, but we've got fairly good data now that the Brazilian variant and South African variants might not be as, our vaccines might not respond so well to them. And this idea of having red list countries and not red list countries is again daft, because of course you can travel to an intermediary country. And so each of our waves we've seen associated with that type of behavior. So, wave 2 in the summer was everybody coming back from, Spain, France, Italy. And obviously because we didn't get our case levels low enough after wave 1. So I think, again, it's what I was saying during our first panel, it's a conversation between civil liberties and trying to do what's best for society. And those countries that have come out of this, like New Zealand and Australia, absolutely shut everything down externally that could impact upon variants. Now, of course, the conversation is now, like we have with flu each year, how much is someone's life worth? You see it on the airline industry with travel safety. Everybody's life is worth a certain amount of money. If it's above that certain amount of money, then the thing isn't implemented. So again, what are we prepared to accept as a society in order to maintain our liberal democracy? So a bit more philosophical, Jane, but
no, it's a fair point, isn't it? Do you say, oh my goodness, that they're still at X thousand cases a day, look at the R number, and travel from that country and to and from that country for the near, into the near future is actually not allowed? I don't know. I don't know what you do. Others, and what are the other risks? Go on, Paul.
We've proven quite satisfactorily that we're rubbish at putting quarantine in place so far. But we've got a vaccine that works. And we also know from previous experience with flu, all the 2 major strains of it, how to update vaccines on an annual basis. All you need for that is the surveillance processes in place. And we have a global surveillance system for flu. I don't see why, if needed, we can't just expand that to include COVID too. and then we keep up with it. I mean, so in the short term, yes, countries that aren't making much effort to control the virus, they are a risk. In the long term, as long as the vaccine carries on working and nothing catastrophic crops up, I think it'll be fine. We know how to deal with that sort of thing. The dynamics are different. I mean, we tend to worry about flu coming from Southeast Asia up to the Northern Hemisphere. We don't tend to worry about it coming from Brazil, but we can adapt as long as we have the knowledge. And governments historically underfund surveillance.
Yeah. Oh, yes.
As you know.
Oh, Paula's there.
I was just going to interject another sort of wild card that I think is going to be a factor in this is the concept of, vaccine passports. And although, everybody kind of goes, oh, you can't force people to have a vaccine. I'm like, no, you can't. But maybe if they want to go to Hawaii, they need to be forced to have a vaccine. So I think that's going to happen. I think it's going to happen at universities. It's going to happen in certain industries, maybe at gyms, maybe cruise lines. There's just going to be so many places where, you need to be vaccinated, and the civil liberties arguments against that are I think they're going to be beaten. So, I think this is our future, and that's going to be a powerful way. You need a carrot as well as a stick to get people vaccinated. And I think in the United States, not being able to go to Hawaii or Florida without a vaccine passport is probably the way we should do it.
We already have that, don't we, to some extent? Aren't there countries where you need to be vaccinated before you go for certain diseases?
Yeah, just not against
China.
Yeah, yellow fever. Yeah.
I totally agree. You don't have a legal right to visit Spain.
No.
Spaniards will tell you that. They'll just turn you away. And I think as well, didn't they used to be, in the days of smallpox vaccination, didn't you used to have a card stapled into your passport in those days? Somebody was telling me.
Oh, I don't know.
Yeah, my mum and dad were banging on about it the other day. When we went to Switzerland in 1963, there was a typhoid outbreak, and we had to show that we'd been vaccinated against typhoid to get back in. So why can't everyone be vaccinated? There you go. That's my parents' rant. I think the question more for us is when do we tell people you can't visit the UK unless you've been vaccinated? No.
That's going to happen, right? Countries are going to say you can't come here unless you've been vaccinated. And there's nothing we can do about it. So it won't be long, I think, before we flip the coin and say, well, no, people can't come here unless they've been vaccinated.
Yeah, I mean, that is the case for yellow fever, isn't it? There's countries you can't get through the, what do you call it? the gates.
The door.
Without your, thank you. Without your stamp in your passport.
And I think as well, there isn't, the Australian airlines are already saying that's going to happen. And Australia, of course, has decades experience of being biologically quarantined from the rest of the world for various reasons. So, they're used to this. And you can't show up in Australia on a roll-on, roll-off ferry or anything. So, they're already planning for this. And I think other countries will follow suit. And I think by default, because you can't say to a country, or legally, you must allow our people in, even if they've been vaccinated or not, I think it will just happen.
Yeah.
The one concern I would have about this is that, any of us who've traveled to countries that need a yellow fever certificate probably know that you can quite readily buy one of those certificates from a man who stands beside, on the door on the way in. So one's got to worry that, what form are these vaccine passports going to take? What evidence? Are they going to be accompanied with an antibody test upon entry? I mean, a piece of paper, as it stands, all you get here is a little piece of card that puts the name of the vaccine on. Is that going to be sufficient? I doubt it. But how do we ensure that this is robust? I think that's my one concern I'd have about them.
But again, I think the purpose of it is not to be perfect. It's actually to be the incentive. Another reason to get vaccinated, stacked up against, the lies and the conspiracy theories and all the things that we have to fight. So always, I think in terms of carrots and sticks. And I just use Hawaii as a really big carrot for people all the time. And I suppose if I was in the UK, I'd use Spain, would I? Yeah, that would be the carrot. Yeah.
So here's one I think probably a number of us have been asked in the past, but I guess well, the sequencing amongst us might have a theory on it, and you know, all you virologists. So was the virus found in the UK or in European countries, sorry, prior to 2020 starting? So this person is quoting French radio and saying that there were French citizens with antibodies in 2019. David's shaking his head quite.
No.
No, that's good. Is that it?
Well, I think
No. Not Italy, not anywhere else. It wasn't magically, secretly circulating. No.
so loads of us have sequenced this virus. Ian, especially on this call, right, has been leading big national sequencing efforts, right? And you can go to this thing, I'm going to try and pronounce it correctly, GISAID site, and you can actually go on and look at the origin of the virus, and all the sequencing we ever done all traces back to China. No matter.
Yeah, I thought we would just nail that one. Quite. Yeah. I've got it in writing that I've said exactly the same thing on more than one occasion.
Isn't the concern is that this idea that people have antibodies, but you know, if you look for antibodies to anything in the human population, there will be the odd person who has some sort of reactivity. But I agree totally. I would say absolutely not. All, you know, all the data that's been presented that this virus was around earlier has just massively confounded by potential sources of contamination and all kinds of things. So no.
Yeah, that's good. Someone asked a question I think we've already answered. What was the most important thing that we should learn from this pandemic and the response? I think panel 2 did a good job of that one. Oh, yeah, it's all right. That's Julian commenting.
Can I just comment on that?
Yeah, please do. Please do.
So it was interesting to hear people talk about wave 1.
Yeah.
What we've done. So in the UK, remember back at the turn of the century, we had 2 foot and mouth outbreaks. One because of imported meat and 2 because of a laboratory release. The number 1 lessons of that outbreak was test and get again. So AVLA, APHA, whatever it is, Weybridge, right, has a mandated testing capacity of thousands and thousands of samples a week for RT-PCR. Pirbright Institute, similar. Defence Lab, similar. And I think it was Ian or one of the panelists was saying, it's not beyond wit nor wisdom that that capacity could have been harnessed right at the start in order to provide that surge capacity for proper contact tracing as you would do it, say, in Singapore, who had SARS before. And so you're identifying contacts of contacts of contacts. And we didn't do it. For whatever reason, the politics, and there was a lot of politics, said, no, we can do it this way. And I think... I
agree, Julian. I saw that facility. It was mandated to test 40,000 samples a week and had to be brought up to speed once a year minimum to prove that it could do it in the event of another foot and mouth outbreak.
Yes, and that's all driven by money.
I mean, you, Jane, I'm saying you and Ian both went to Ebola land, and the number 1 thing
did David.
Was testing people, wasn't it?
Yeah.
Right, that's what it was for. European Mobile Lab, PHE labs. Can you differentiate between malaria and Ebola? Ebola positive person, bam.
Yeah.
So I also think, you know, we have to think about the sort of the collective attention span as well around things like this. I'm very struck by, in the United States in 2001, 2002, you know, we had some sort of terrorism attacks, the big anthrax scare. And as a result, the US government, the National Institutes of Health, led by Tony Fauci, set up these sort of massive regional, what we call centers of excellence for biodefense and emerging infectious disease. And they ran for about 10 years. And they were fantastic because they brought together whole groups of people, and we'd think about, you know, worst case scenarios of both, you know, terrorism attacks, but also about pandemics and things like that. And we started to build capacity in academic centers, and we all sort of knew each other. And then they all went away because, you know, we didn't get another anthrax attack and we didn't have another pandemic. So I think what I worry about is the sort of attention span. And you've seen it in the UK where, you know, there was a lot of effort at the University of Oxford around developing vaccines against the original SARS, which luckily they kept everything in the freezer so it could be brought out and repurposed. But just this idea that, you know, we're going to pay attention for a few years and then sort of just go back into thinking it's not going to happen despite all the evidence. So I'd like to see us, you know, sort of develop kind of, if you like, platforms that are ready to stand up the next time this happens, both in terms of testing, tracing, and vaccine development, and starting to sort of do some work now looking for sort of, you know, antivirals or antibiotics that we're going to need. And hopefully we can have politicians who have a bit more of a long view of this and see these lessons that have come at us hard and fast from nature, that we need to do this because it is going to happen again.
So that makes me laugh, Paula, because, you know, I've worked on and off for coronaviruses for quite some time. David here was probably the last person in the UK to be on a grant on human coronaviruses before the outbreak. And he had to get that funded through the BBSRC because the MRC wouldn't fund it.
Right.
We had a grant in at the end of first SARS outbreak, Alpha A rated at the panel. No future in coronaviruses. We don't need to do it.
Yeah.
You know, and we saw the same thing after MERS. And, you know, some of these things will come back and bite us.
As they indeed have done. So, yeah.
Jane, can I just do a tiny thing just on the mass testing? So it does.
Yeah.
So it is worth just realising that testing lots of people does have lots of advantages, the case ascertainment, putting in controls, but it isn't without disadvantages, and we do need to have a strategy. Strategy isn't to test 100,000 people a week. That isn't a strategy. That's just a, you know, that's a number that is fed out. The strategy is about testing the right people at the right time with a plan of what to do when you have a positive, and understanding some of those positives won't be true infections. There'll be false positives, or there'll be people that have a, you know, long-term positivity because of the assays that we're using. So just
you're right, but to disagree, we had the capacity back in March, April to do the numbers we needed to do, and we didn't. And we then went to symptomatic testing, i.e. if you're symptomatic, you isolate, despite the fact that we have asymptomatic spread. And we know the results of that.
Yeah, but I suppose what I'm saying is that we absolute capacity is always going to be an issue, but if we can overcome that, that's great. But we also need a strategy to go with that testing program and realize that there will be some disadvantages for the individuals as well as the community if we have a mass testing program without sort of describing what we're doing.
I think as well, we could have a mass testing program that adapts quickly to whether it's an animal disease outbreak or a human outbreak or even a plant disease outbreak. Do you know what I mean? Because the basis of the testing is the same.
Yeah. Just be quicker off the mark and be prepared to use those institutions. Got a technical question, probably Dix and Nikki, I think. Could you combine I suppose it is a purely technical question. Could you combine the existing flu vaccine and add in one or other of these, a COVID vaccine? I know they're different makeups, so I can guess what the answer is here, but is it going to be possible perhaps with the AZ vaccine, Paul?
Nikki, you're the expert here. Do you want to answer? I know my opinion.
I'll take it. I'm going to give quite a sit on the fence answer, actually, because I think it does depend, and it will be based on how compatible the two vaccines may well be working together. We do have vaccines that are used in routine immunizations, particularly childhood ones, that combine a number of different types of vaccines for different diseases together. But that's been a process of understanding how those might interact, how you formulate that particular vaccine such that each component still works effectively, even though it's given at the same time as something else. So I think there's probably more work to do on that, and I don't have the answer to say whether that could happen, but the art of the possible. So there'll be people that can be looking at this. It also comes down to timing. So our flu vaccination season is autumnal for the Northern Hemisphere. And that may not necessarily be the time when we would want to vaccinate for COVID. So it's also a timing issue as well as a practical one.
Go, David. Yeah.
I may have completely misread this, but I could have sworn I saw a recent call out here in the Southwest, because obviously we have a vaccination centre here in Bristol, to look exactly at this question of could you vaccinate flu and COVID at the same time. But I may have misunderstood what they were asking for. But
So do you think that's just somebody coming in and will vaccinate you with this vaccine for COVID and this one for flu? Or are we talking about a combination vaccine, which is obviously not yet available?
I can't be sure what it was. I just remember seeing it, and it was talking about if you've had one vaccine already and there is, and you haven't had the second one, then we're doing a study on co-vaccinating with flu and COVID. But I don't know whether it was literally in the same injection or 2 injections at the same time, or what it was talking about.
That's quite interesting. So we're at the end of the flu vaccination season, if you like, for the Northern Hemisphere. So that might be a very good opportunity to do that.
So I remember one of my students asked me the question, Nicola, and to my shame, I don't remember your answer. But this was the question that if they come from another country and they have been vaccinated there by a vaccine that does not exist here, is there then an issue with them getting a booster vaccine when they're here and students are being vaccinated with something completely different? And I guess as a correlate of that, could there even be an advantage to doing that?
So again, too few data, I think, at the moment to know what the efficacy might be. But there are studies ongoing to look exactly that. And no doubt there have been examples where somebody has received vaccine A to start with and gets to the vaccination centre and maybe given vaccine B, by accident, or because that's what they had for their second dose. So there's possibly examples where that's happened anyway. But there are studies to look at perhaps the pros and cons, sort of the immune advantages of having the first and second dose being exactly the same vaccine, or even the same type of vaccine. So could you have an RNA and an RNA, or an RNA and an adenovirus? So there are lots of combinations, and the more vaccines that come through, the more complicated those studies will become. But it's not outside the realms of possibility, and recognizing that, and also the flexibility. Knowing that, say, you couldn't get one vaccine, but there's another one available, knowing that will still work and still boost your immune response, those things will be really valuable to understand.
So a virologist might have said in a newspaper recently that she speculated as to whether if it would be with a vaccine, one of the vaccines we use that may be giving slightly more side effects. Not side effects is the wrong word. More of a response when you are vaccinated. Could that potentially be was there any potential for that to then act in a sort of more adjuvant-like way? Have G'd up the immune response and actually give a better antibody response? And did they look at that side of things? I can't remember in the vaccine trials.
Jane, I don't know, I mean, as all the panelists know, my immunology is fairly crap, but my understanding is that the Pfizer vaccine gives you higher levels of antibodies than the AZ vaccine.
Okay.
And the AZ vaccine is still protective. And so if you've got like the South African variant, the reason why maybe the Pfizer vaccine is more effective is simply because it has higher antibody levels, not because it's specifically designed against the South African variants. So yes, the the vaccines will be different in the neutralizing antibodies that they make.
Giles.
This is actually a question from my wife, who's an immunologist, Jane, back there. What is the danger of actually T cell exhaustion? Either through, if you've already had it, had COVID, and then you got 2 injections of the same vaccine, or if you actually had 2 different injections of the same, multiple injections of vaccination.
So can I go again?
Go.
So I don't know about T cell exhaustion. I've heard it for something else. I can't remember what for. But for me, and I think David will disagree, for me, this vaccine's about circulating B cells, because we know with normal human coronas and SARS and MERS that your immunity wanes after 9 months to a year. And then that's it. And so it's all to do with neutralizing antibody levels, not necessarily T cell. But as I say, my immunology is rubbish. It's probably Paula will now launch in.
I will launch in. I would just say it's probably worth reflecting that we don't yet know what the correlates of immunity from a vaccine are. And you know, one of the challenges we have is that, you know, we look at what we can measure. And as you guys all know, an easy thing to measure is antibodies in blood. It takes minutes. But what we're measuring is kind of, you know, total antibodies that could stick onto the coronavirus. And that's different than the much smaller subset of antibodies, which are actually going to stick on the coronavirus and stop it working. And then we're sort of completely ignoring, because they're much harder to test, you know, from a drop of blood, the whole army of T cells which come in and chew up, you know, virus infected cells and are probably going to be playing a major role. And then also other types of immune cells, the NK responses and more innate immunity. So there's this, our immunity is this whole, you know, army orchestrated to fight against the virus. And we measure this one aspect of it, total antibody level. So I think it's going to be, you know, and we will get this data as we go forward. We will start to understand what is it we could detect in somebody's blood that would tell us, hey, you've got really good immunity, or maybe you need to get a booster, and how long it can last. But it's, I mean, I got my antibody levels checked before.
I'm going to have to be rude, Paula, sorry. I'm going to have to be rude and cut in, because this thing will cut us off in about 10 seconds, I think. The webinar just ends. I'm going to have to, I'll catch up with everybody after this, but I am going to have to pull us to a close and just thank our audience for their questions and their, you know, interest and participation, which has been really helpful. And I hope they've all had, you know, got something from this as well. I hope you've enjoyed it. I can't thank the panelists enough, actually, because I think that was a pretty broad talk through COVID, actually. That was, you know, a good talk round and through, and I thought some very positive looks into the future. We're quite clear on what we should be doing better, and hopefully Professor Digard's convinced us that it's all going to end happily ever after, and we'll all be fine. So thank you very much, and thank you to Ella for managing all this, which has been great. If the speakers want to join me in Zoom afterwards, please do. Another Zoom. I've emailed you the link. Oh, I missed a question. Oh well, I apologise. I thought I'd got them all.
Thanks, Jane.
Thanks. Bye, everybody.